Welcome to our roundtable. I'm Jamile Shammo, a hematologist from Northwestern University. And today we're going to be talking about treatment options, specifically focusing on patients with low-risk MDS in first-line setting. Today I am joined by a panel of experts, and I would like them to introduce themselves.
Hello, I am Melhem Solh from the bone marrow transplant at Northside Hospital, Atlanta, Georgia.
Hi, I'm Somedeb Ball from Vanderbilt University Medical Center in Nashville, Tennessee.
Hello, my name is Bart Scott. I'm from the Fred Hutchinson Cancer Center in Seattle, Washington.
Hi, I'm Palmisiano from Rutgers Cancer Institute.
And hello, I'm David Swoboda from Tampa General Cancer Institute.
And our goal today is to talk about how do they decide on what to choose in terms of treatment for patients who have MDS. What is their timing for initiation of therapy, and what is the sequence that they would utilize in this setting? Today, we're going to be discussing treatment options for low-risk MDS in particular, focusing on timing for initiation of therapy and choice of therapy as governed by certain parameters, perhaps transfusion need or other biological markers, etc.
I want to see more data in transfusion-independent anemic patients. That's the large majority of our patients, and hopefully large majority before they get the care for their MDS, right? Because that means we are doing great in catching them early and intervening early. Now we have great tools at our toolbox and more in the investigational space. Maybe some of them break through over the coming years, and we come up with combination studies targeting different mechanisms in the erythropoiesis biology, and that gives us option to probably intervene soon enough so that we don't get to the transfusion-dependent phase. So I think I would look forward to that data. The other thing I really a strong believer at the end of the day for these patients with MDS, they don't die from AML transformation per se. Majority of them would live for 10 years, 5 to 10 years without AML transformation. So we should have these benefits that we are seeing in anemia being tied to overall survival, hard outcomes like overall survival or quality of life improvement. Now, what tool you use to measure quality of life is always a question. So maybe a standardization there, more easy to use tool across clinical trial would be welcome, not like 34 question tool like COMS, maybe a shorter one that can be validated. Wearables are coming now in investigation. Maybe that's a better way. We all wear our smartwatch, maybe a better way to measure what we are doing throughout the day. I think those kind of innovations I'm looking at, because at the end of the day, what matters is how patient feels.
I would say disease modification, which I think is something that hasn't really been focused on in low-risk MDS. We've been more concentrated on improving symptoms, which is great. I think that's fantastic. But ultimately, it would be nice if we could, quote, cure low-risk MDS, end quote. And I see that as a potential future. I mean, we know that some drugs cause decreases in mutational burdens that we've been giving. And there is some evidence that perhaps some agents can delay progression of CCUS, for instance. So I think disease modification is the future.
Yeah, and what I'm most interested in is seeing what the sequence of these drugs, what the perfect sequence of these drugs is until we get to that place where we are curing people, to give people the maximum amount of time transfusion independent. And I think that that's a real unmet area.
Yeah, I would say from my perspective, I like the idea of really starting to do more combination therapies, whether it's LUSPA plus ESA, whether it's imetelstat, actually starting to introduce that even earlier and think about potentially modifying the disease while also improving hemoglobin values. I think it'll be interesting to see it evolve. Is sequencing therapies better, or could we get to a place where starting therapies, even in combination earlier, ultimately leads to much better outcomes and much better quality of life, as Dr. Ball was saying earlier, for our patients, especially in the patients that are kind of the challenging ones, high heavy transfusion burden, high molecular burden, the ones that we think might not generally respond as well to luspatercept or ESAs by themselves.
I think, I mean, all of these valid points, we have to keep in mind a lot of these patients they have very long survival. You have to worry about the side effects of combining medications, of a lot of newer drugs. You know, we all remember for 5Q, you give Revlimid, which is a great drug, but most of the time physicians can't keep them on the drug from side effects. So one advantage of luspatercept, it's safe to give. The side effect profile is very easy, and that's why we're sitting here talking about a survival advantage, because they can stay on the drug. I agree with Scott. I mean, definitely MDS, we're still far behind in addressing the disease. I mean, we're still just treating symptoms. Short of a transplant, there's nothing else you can cure an MDS. And up till 3 years ago, we had nothing in the last 2 decades.
And suddenly we have a plethora
Yeah.
of medications. So I think what I would like to see, and I totally agree with everything that has already been said, I like to see more incorporation of some of the molecular data into the risk assessment, and what does that mean for the patients, and do we have any other identifier that can tell you, hey, you know, this person probably could benefit from HMA's first line, you know? We don't have that kind of discerning capabilities for our patients, because all the clinical trials didn't include all of the above. And you have to kind of compare a trial to the other, and we all know that that's probably not the best way to do it. So a little perhaps more understanding of the biology of the disease and incorporating that into our decision choices and the available therapeutic options. And it'd be great if we can get even more treatment options for this patient population, because to your point, they live for years, and we need to have a little bit more for them. I suppose that these are all interesting things that are available right at least by clinical trials, and the concept is very interesting, right? That if you are reducing the inflammation, perhaps you're modifying the clonal hematopoiesis, et cetera. But I honestly think that my take on this, and I'm curious to see what everybody else thinks, is that modulating one pathway is probably, it's interesting and it should be done, but the cell is so complicated, right? And you have various pathways that you might be blocking one and then opening the likelihood of activating some others. So I think these are all interesting trials that we have to learn from. But were you impressed by the results?
Well, I think it's just interesting to have another target within low-risk MDS, another class of drugs to potentially explore. Yeah. So I was happy to see that.
Yes.
Yeah, I would say right now, like you said, because there's a lot of different targets that you can within the inflammasome pathway. You know, they picked one. Is it the right one at the end of the day? I think it's just too early to really tell if that's going to have any significant impact on patients in real clinical practice.
Yeah, I'll just share an optimistic way to follow the thought of Dr. Scott's on cure, quote unquote. So there was a nice abstract presented in one of the basic translation session by Omar Abdullah from MSK, where they did mitochondrial transplant. And it actually, and those, they saw it working in the lab and they translated it into a clinical trial. The clinical trial was run mostly in Israel and it's coming to New York, but it's interesting to see after multiple different therapies, including imetelstat, patient living transfusion independent for several months after one mitochondrial kind of transplant infusion. There's no conditioning, nothing else. So, I mean, maybe that's the way to go. That's the way to reset whatever is going on in the MDS microenvironment to kind of fully, and of course, these medications will stay, but if these are failing, maybe we look forward to something like that to reset the microenvironment all total.
I'll also end on a positive note and just reflect on the history of MDS and how much things have improved. And it seems like the rapidity of that improvement is increasing. So I'm very pleased about that. I mean, when you think about all the years that we've been coming to ASH and coming to the meeting, the levels of new therapies that are approved for MDS have just kind of skyrocketed, it seems like. So I'm very encouraged by that. I'm encouraged by some of the trials that we've mentioned. The study you mentioned sounds amazing. So we're really discovering new things all the time, and it seems like the rate of that is improving for the patients.
Yeah, and I totally agree. I think we're in a nice place currently to be able to, debate and talk about several different options that we can use for our patients. Because even just a couple years ago, most of these were not available at all and not approved. And so the fact that we now can think about, is there molecular subsets that might respond better to one another, and really start break down biomarkers for response to these individualized therapies, mean we are like moving in the direction beyond just a one-size-fits-all type scenario in MDS, which 10 years ago you would might not think would be possible. So definitely made a lot of progress, and now we can continue to build on that progress moving forward.
Well, I'd like to thank the panel for a provocative discussion on the management of low-risk MDS. Thank you all for participating.
Thank you.
And thank you for joining us.
Thank you.
Thank you.
Thank you.